I think it's now my great honor to introduce Professor Neuhaus, who actually does not really need an introduction, but for this interesting case about percutaneous transhepatic cholangioscopy for hepatolithiasis. I don't think you have seen many videos on this.
Yeah, so I'm reporting on a 21 years old female patient who was born with a Tudeni type 1C of bile duct cyst, and at the age of 2 years, she underwent radical resection, hepaticojejunostomy with a Roux-en-Y anastomosis. And she was fine until until the age of 18 or 17. But then she developed recurrent epigastric pain with normal laboratory parameters. Transabdominal ultrasound followed by MRCP showed intrahepatic stones in dilated bile ducts. And MRCP shows the biliodigestive anastomosis after hepaticojejunostomy. And as you can see, the central biliary system, the right hepatic duct up to the periphery and the left side are completely filled with stone material. So, of course, we always try to solve these problems with enteroscopy. We now use the spiral enteroscope to approach a biliodigestive anastomosis in altered GI anatomy. But I think even the most enthusiastic endoscopists will agree no chance to solve this problem via the peroral route. And this is to avoid surgery, which would be very complex and challenging and also associated with increased risk. Is the only option is a percutaneous access. And as you can see, I did the PTC on the left. You see the opacification through a Shiba needle. And at all sites where you see the yellow arrows, stones were completely impacted. A large dilated duct, but also stones on the left side. So it was quite difficult even to pass a guide wire alongside the stones and to approach the jejunum through the anastomosis. And then we dilated the tract in 2 further sessions to 16 French. So usually 12 French is enough, but we need enough space for stone removal. So on day 8, we performed percutaneous transhepatic cholangioscopy using the Spyglass Discover, which is quite similar, the basics technology, to the Spyglass for peroral cholangioscopy. It's a fully integrated system, CMOS video technology, 2 LEDs, 4-way deflection. And as you can imagine, manipulation is even easier because it's quite short, 65 centimeter in length, 10.5 centimeter French is the distal tip width, and it's single use, and it has a 1.2 millimeter working channel. So this is the tube. We inject now a contrast to confirm the correct position on day 8. So we place a guide wire as a pathfinder. Usually you can, after establishment of a stable continued transhepatic fistula, you can also directly insert the scope, but to be on the safe side and to find the way between the stones to the anastomosis, it's safer to place a guide wire. And this is the device. As you can see, excellent maneuverability and angulation capability. And now I activate flushing, which is very active. Patient is under deep sedation, so no general anesthesia, but she has a nasogastric tube to avoid aspiration because we have to flush a lot. And then without the sheath, I directly insert the scope through the percutaneous tract to the transhepatic tract, approaching now stones in the right liver lobe, going alongside the stone or the multiple stones. We are now in the left hepatic duct, as you can see, so we cross the confluence and pass the scope through the anastomosis into the jejunum. So now we pull it back to the confluence, and you can see the excellent maneuverability. So I decided firstly to fragment stones in the left liver lobe. So I'm inserting the EHL probe with the autolit generator. So you see the position. You see that the duct is completely filled with stones. No contrast material passing into the left side. And now we start to fragment the stones. And in this case, you see the excellent flushing capability. And it's very important that you have a good flow through the anastomosis, because otherwise you have only debris in the duct and you cannot proceed. And then we push the fragments with the tip of the scope through the anastomosis into the small bowel. So this is the concept. We don't pull the fragments through the sinus tract, because this is not really stable at this stage and it's very time consuming, although now we have also baskets for this device, but it's much easier to push them through the anastomosis. And now we cleared the left side. You see the exit to segment 2, 3, and 4. We inject contrast, so we reopened the left side, but now we have still a completely filled right hepatic duct. As you can see here, full of stones, blocked. And therefore we continue fragmentation, flushing, careful pushing the fragments towards the confluence and then through the anastomosis. And you can appreciate the excellent visualization and safety, because we can precisely control the position of the tip of the EHL probe, and we push it through the anastomosis into the jejunum. And this is, by the way, the stump after the Roux and Y anastomosis of the efferent loop. So now we still have very small remaining fragments, which are then difficult to remove, but they should pass spontaneously. As you can see now, ductal clearance within a single session. But to be on the safe side, we keep the track open by placing percutaneous, as you can see, maybe small residual fragments, but otherwise clear ducts up to the periphery. So we place these kind of percutaneous transhepatic tubes, which are soft, have side holes, and they are blocked at the skin level. Patients flush it once a week, and they are not really disturbing. And the advantage is, as I said, you keep the tract open. So, and the patient come back 2 days ago. We removed the percutaneous tube. There's a little debris here, but that's all. You see a completely cleared ductal system, the hepatic confluence again. We now enter the left hepatic duct, again, segment 2, 3, 4. We pass the scope through the anastomosis. To the jejunum. So this is nicely open, otherwise you could dilate it with a balloon. And for those who don't believe in cholangioscopy, we inject contrast if you wish. If you need a cholangiographic control and you see clearance. So we didn't insert a new prosthesis, and the percutaneous fistula will close within 1 day. So this is the end of the procedure. Thank you.
Thanks for this very nice demonstration. I might have missed it in the beginning, but did the patient come into the room already with a PTC drain, or you did that all in one procedure?
No, we had the MRCP findings, and then I did the PTC.
And then in the same session, you continued with this cholangioscopy?
No, I didn't. No, we placed the percutaneous catheter, and then we dilate it in 2 further steps to have a stable track.
Okay.
You could, theoretically, you could do everything in the same session, but then you need a sheath, otherwise you have a leakage. And finally, you have to, in any case, you have to leave a tube, otherwise you have a high risk of leakage. And when you flush a lot and you have no stable track, then it's a high risk of leakage and of biliary peritone.
Yeah, exactly, because you immediately went
Yes.
in with the scope, so I was just a bit
Yes.
puzzled.
Yeah.
And how much probes did you burn on her?
Just 2 probes.
Wow.
Only 2 probes, yes.
And how high is the chance that it might come back?
Of course, there is a chance. The patient knows that, and we recommended to undergo MRCP in 1 year to detect recurrences at an early stage, and then if there are smaller stones on the follow-up, then we could approach it from the peroral route.
And
By
is there any rule for ursodeoxygolic acid?
No, there is no proof that this helps in intrahepatic stones.
Okay.
Yeah.
Thanks. Nice presentation.